Hello, everyone. I'm Professor Melissa Goldstein from the George Washington University. We have a wonderful lineup of panelists today, and I'm very happy to welcome you to our July Ethics and COVID webinar series. Today, we'll be focusing on mandatory COVID-19 vaccination for healthcare personnel, which has been the subject of very recent news and more and more accelerating in the past few days. We had quite a few news stories yesterday. In fact, for instance, in the New York Times, it was noted that New York City and the state of California are now both requiring state employees to either get vaccinated or have frequent COVID tests. This includes municipal workers in New York City and the state workers in California. California has also announced that that the state is going to require some private healthcare workers to be vaccinated or tested as well. The Department of Veterans Affairs yesterday announced that it's going to be the first federal agency to mandate that some of its employees get inoculated. The mandate is going to apply to workers who are, quote unquote, the most patient facing, including doctors, dentists, registered nurses, physician assistants, and some specialists. At the same time, yesterday, a group of nearly 60 major medical organizations, including the American Medical Association and the American Nurses Association, issued a joint statement, which is a big deal among these 60 very diverse groups, all of them calling for mandatory vaccination of healthcare workers. In particular, the statement describes it as an ethical obligation. So these are the facts as they stand today. We have three very esteemed panelists that we're going to speak with today. First, we have Dr. Nasir from Houston Methodist Hospital and many other, I believe their bios are on our website, but he has over 500 peer-reviewed articles in such journals as The Lancet, New England Journal of Medicine, JAMA. He has an MD and an MPH. He completed his internal medicine residency at Boston Medical Center and a cardiology fellowship at Yale University. We have Mr. Bryan Thomas, who's a senior researcher and adjunct professor with the University of Ottawa's Center for Health Law Policy and Ethics. And we have Dr. Preeti John, who's a general surgeon with a fellowship trained in trauma and critical care. She's triple board certified in the following specialties: general surgery, surgical critical care, hospice, and palliative medicine. So I want to hear as much from this group as we possibly can. We're each going to speak, they are each going to speak for briefly 5-10 minutes, and then we're going to open up for questions from the audience. Please put your questions in the chat and I will modify the questions. So we'll have speaking for until probably around 12:30. And then we'll have a lot of questions from the audience and responses from our panelists. So let's go ahead and get started with Dr. Nasir, and I will mute myself and let us hear from the experts.
Thank you, Dr. Goldstein, for the kind introduction. And I'm just going to get my slides ready in a minute. Let's see. Got it. Can you see the slides?
Yeah.
Okay.
Yes.
So just to start, well, I think what a year and a half it has been. So who would have known that a new pandemic will infect nearly 131 million people and cause more than 2.8 million deaths worldwide, and even in US becoming the #1 average daily deaths locally. Major shocks to all aspects of the society. Pushing, I would say, more than 100 million into poverty with decades of economic gains lost. But for us in the healthcare industry, apart from personally experiencing the ill fortunate of our most important stakeholders, patients, we also witnessed significant suffering in our own community with frontline workers about 4 to 10-fold higher risk of contracting COVID than the general community. And not only that, maybe the leading cause of workplace-related death ever among healthcare workers. Just in US, more than 2,900 healthcare workers died this year, and which is unprecedented. And not to forget that many of our colleagues who contracted COVID and thankfully survived continue to suffer significant disability, prolonged recovery that presents at significant pressure on an already resource-restrained healthcare system. Now, while we are waging this collective battle last year with mostly PPE, our hopes were really rejuvenated with unremarkable collaborative efforts worldwide, bringing rapid emergence of multiple vaccines. Now, within 12 months, COVID-19 vaccines developed showed that not only they are effective in the general community, but also for asymptomatic and symptomatic transmission among healthcare workers, as shown by initial insights from Israel, then large-scale study in the US, and furthermore in the US. However, despite prioritization and I think unfettered access in majorly, at least in high-income countries like US and UK, vaccination remains suboptimal and disproportionate, because if you look at many studies reported that at least in US among healthcare workers surveyed, 18% said that they didn't plan to get a vaccine. Another 12% said they were undecided. In UK, this number goes up to almost 25%. And if you look at the recent consortium led by Dr. Saad Umar from Yale, interestingly, in low middle income countries, the vaccine hesitancies was lower than US and UK. Now, even among practicing physicians, while 96% have been vaccinated, the rate really drops to less than 50% among nurses and aides. And especially in nursing home, even though outbreaks and that have been worse in that setting. And with majority of the 40% of the COVID deaths in the nursing homes and more than 1,500 nursing home staff dying, it's hard to disagree with this Washington Post op-ed that nursing home caregivers may have the most dangerous job in America. And furthermore, even with that, in US, we are also seeing a significant divide in COVID vaccination rates between rural and urban America. And by the way, this is nothing new. If you look at the healthcare vaccination coverage rate has been suboptimal for other vaccines. And as a result, many countries and institutions have implemented mandatory vaccination policies towards some of these vaccine preventable disease. Now, over the last 6 months, many universities, including I'm sure most of where you are, and other industries such as even the United Airlines Delta mandated vaccine, I felt a few months ago the silence from the leaders in healthcare industry who are truly at the front end of this fight was deafening. While everyone was pondering on 31st March, we were all pleasantly surprised and proud of the Houston Methodist leadership, rather than waiting for others, taking the lead and becoming the first healthcare system in US mandating COVID vaccination for all its employees. Now, as quickly as the mandate was announced, it led to questions. While Houston Methodist leadership defended it strongly as part of their fiduciary duty, many others wanted to try the non-committal Goldilocks approach, fantasizing that the full vaccination can be achieved without the mandate with just nudges and incentives. Now, I admit that a mandate for COVID-19 vaccination among healthcare workers present political, legal challenges in democratic societies, and even potential ethical and practical constraints that cannot be completely ignored. And as evident by protest against healthcare organizations who were considering vaccine mandate. In fact, a week and a half back, over 100,000 people protested across France on the government's latest measure to push people to get vaccinated and curb rising infection by the Delta variant of the coronavirus. Not only that, even some medical experts including prominent cardiologists, were loudly advocating against vaccination. Now, we have seen this story before. Similar large-scale protests were seen against vaccination for threatening conditions such as smallpox almost 135 years ago, as depicted in this picture for protest in Leicester. As compared to current situations, many anti-vax groups use the same tactics. Number one, declare vaccination as a part of a large conspiracy and public health measure depicted as an assault on personal rights and overreach of the government. Minimizing the threat, again, was a common tactic in contemporary debates, and also claiming that the vaccine is more dangerous and using alternate authorities to legitimize those arguments. We are seeing that all over again now for COVID vaccine. As we move forward, I think the availability of vaccine and these debates on the mandate has raised the issue where these are ethical. And even more challenging is that the mandate of a product that is yet not fully authorized. So we can review the ethical considerations of the mandatory COVID-19 vaccination policies within the broad framework adopted by Buchan and Childress, and I think even widely used at WHO, so that can influence the participatory decision-making on vaccine requirements. Admittingly, a mandate for COVID-19 vaccine, first, if you look at the clinical perspective from the beneficence and non-maleficence, the clinical ethics clearly prioritize our fiduciary duty of ensuring beneficence and non-maleficence in healthcare worker-patient interaction. And there is little doubt today that in the present scenario, the duty to keep the medically vulnerable patients safe from becoming infected is our top priority. Although there may not be enough evidence to robustly quantify the effectiveness of healthcare worker COVID-19 vaccination against nosocomial infections, the evidence of fewer deaths among nursing home patients and elderly hospitalized patients in seasonal and H1N1 influenza vaccine that was associated with healthcare vaccination is reassuring. Second, also we know that COVID-19 is associated with extensive healthcare work economic burdens, cost, lost days, general societal disruption, and high burden of morbidity and mortality among our own community. And as a result, I think it's a good rationale and an act of beneficence. Thirdly, I strongly believe that the general public perceives healthcare workers to be more aware of healthcare issues. And in this light, any hesitancy or refusal in the public to voluntarily vaccinate against COVID-19 vaccine, equation by healthcare organizations on vaccine requirement can lower the vaccine confidence. I believe that the healthcare organizations through vaccine requirements can exemplify our professional obligation to maximize the immunity as a public good for vulnerable patients, an example of community altruism, while fulfilling the duty to protect itself. And even if you look from the patient's perspective, would you prefer to come to a place from apart from providing additional preventive measures, for example, driving a car with additional airbags on top of the seatbelts? I think this is the main issue. There is little debate on the public and personal health issues like the beneficence and non-maleficence as we speak. I think we need to discuss more this related to autonomy and justice. Now, opponents of vaccine mandates, they're mainly on the premise their resistance to the infringement of autonomy and personal liberty. Though not compulsory, most mandatory vaccine policies will likely place constraints to individual choice by some form of repercussion for non-compliance. At the same time, I think we need to be cognizant that any curtailment of individual freedom, which is truly a constitutionally enshrined liberty, should require significant deliberation and justice. But at the same time, it's critical that the emphasis needs to be on true serious risk, not speculative, theoretical, or remote risk. So in our view, these are the main justifications. Number one, we believe that vaccine compliance among healthcare personnel is vital to individual patient safety and broadly to the continued functioning of the health system. It also fulfills the principle of justice with equitable distribution of benefits, risks, and cost, and benefiting the least advantaged, that are our patients in society. In this way, healthcare care worker vaccination could offset the disadvantaged individuals, for example, the immunocompromised or those who have medical contraindications to COVID vaccine. Second, some may suggest that in presence of alternate measures such as masking, physical distancing, physical barriers, prevent the spread of COVID-19, these options are available to healthcare workers, so why mandate vaccines and they may not be ethical? Although, while if you look at in the case of the COVID-19 vaccine, while it's true that universal masking do diminish the risk, transmission beyond these measures have been well documented. Furthermore, redeployment of scarce resources, for example, to these individuals to be non-patient or physician-facing jobs, regular testing of unvaccinated, ensuring that these individuals do not come in contact with other healthcare workers or patients, I believe are literally impractical solutions burdening an already an overstretched reserves. So while other measures exist to control the spread of COVID-19, they're likely inferior to vaccinations and are not without their own problems, and we can discuss them in length. They are at best adjuncts to effective vaccine, but not a replacement. Thirdly, if you look at the issue in the US, especially through the lens of the Model State Emergency Health Power Act, it grants public health powers to state and local public health authorities, ensuring strong, effective, timely planning and responses mechanisms to public health emergencies while also respecting individual rights. In this regard, of course, the landmark Supreme Court case of Jacobson versus Massachusetts, where the court upheld an ordinance in Cambridge that required all adult citizens to be vaccinated against smallpox in the wake of an epidemic. I think this broad ruling gives healthcare workers limited legal ground to object. There is also fourth precedent and legal grounding to legitimize COVID-19 vaccine mandates for healthcare workers in US. For example, we already have influenza mandatory vaccination almost universally in US, given the greater threat posed by COVID-19 than influenza, not only in terms of infectivity and mortality. A mandatory vaccination policy seems even more justifiable here. Fifth, I think so in the ongoing debate around conscientious objection versus a closely related principle, which is the obligation to follow the law, is important. In democratically organized settings, we all have an obligation to follow the law to create a safe and productive society. Now, if we allow an individual healthcare worker to oppose an organizational policy that maintains safe environmental work environment, it could truly dampen the ability of health systems to protect their patients and public health. Furthermore, some may suggest that mandates eliminate the right of informed consent or refusal to treatment, which is not true, as individuals have options of not considering to continue their position and seek additional opportunities. And while the potential threat of losing employment can be and seen by others as coercion, I think it's not much more than asking a school bus driver to wear a seatbelt and drive at a certain limit. And I would also argue that autonomy of a healthcare worker cannot supersede autonomy and benefits of patients, where as a healthcare worker, I can choose between vaccination and my job. Patients usually cannot, whether or not to get sick or choose who care for them when they're sick. They might have no alternative but to be treated and cared by the unvaccinated healthcare worker. And even if you look at the philosophy of John Stuart Mill, personal freedoms can only extend so far as they do not infringe on the legitimate interest of others. I believe in autonomy at all cost. Interpretation may hold sway in situation where one's action, or in this case, inaction, pose no harm to others. Now, the final, I think, so consideration in the autonomy and the justice piece is that the major challenge has been in the absence of the full improvement and approval and utilization under the US Emergency Use Authorization Statute. Now, if you look at the statute, the opposers of COVID-19 vaccine mandate cite the first segment of the provision as a rationale to prohibit mandates. As it states, a person must have the option to accept or refuse. However, where I'm looking from it, it's a different interpretation, and I'm thinking more about the second segment of the consequence and argued that this institutes a legal place for a mandate, especially in the healthcare setting. But till now, there has been no legislative precedent for the interpretation till now. However, in the lawsuit against Houston Methodist, my organization, the US district judge upheld the hospital vaccination policy. I'll share with you some of the key points. The court ruled that the mandate of the COVID-19 vaccine under the current EUA approval did not constitute a human trial, did not violate the federal law requiring human study participants giving legal and informed consent. This is not a coercion. Methodist is just trying to do their business of saving lives without giving them the COVID-19 vaccine. It's a choice made to keep staff, patients, and their family safer. Plaintiffs claim that the current available COVID-19 vaccine are experimental and dangerous, and they believe that the argument is both false and irrelevant, and the Texas law only protect employees from being terminated for refusing to commit an act carrying criminal penalties to the worker, and receiving a COVID-19 vaccine is not an illegal act. And the judge also denounced the plaintiffs for equating the vaccine mandates to forced experimentation and saying equating the injection requirement to medical experimentation in concentration camp is reprehensible. So not only this, you've seen that now there is at least some legal precedents and some judgment about the EUA. And as Dr. Goldstein spoke about, in fact, now there is a widespread support just yesterday with AMA and nearly 50 other medical groups unequivocally calling for healthcare and long-term care employees to require their employees to be vaccinated. And similar mandate was also adopted by the VA, the first federal government employee doing so. Now, I think if we look back from March 31st, the bold move by Houston Methodist inspired a dominoes effect with more than, I think now 50 healthcare systems in US, and at least now Italy, France, and Greece all adopting healthcare vaccination mandates for their healthcare worker. While this is encouraging, I think it's not enough. And we need to overcome the inertia and encourage others to follow. And for those who are interested, I think they can take a leaf out of the Houston Methodist playbook that included slowly beginning with continued education, promotional campaigns, laying the ethical ground, compelling patient safety concerns, ensuring that the healthcare workers fully understand both the empirical and moral rationale for the mandatory vaccine program, employees made aware of the mandatory vaccine programs and the consequences of failing to comply. And these programs only adopted after persuasion or nudging and incentives didn't result in 100% compliance. And these vaccine policies were transparent with different stakeholder perspective, including in the policy development. More importantly, hospital providing free vaccinations and easily accessible. And at the same time, in case of medical conditions that significantly increase the likelihood of a serious adverse reaction, having them exempt from mandatory vaccine policies. So in conclusion, I believe that while implementing mandatory COVID-19 vaccination policies by health systems and other industry sectors in this public health emergency do test the boundaries of personal autonomy. However, we believe that thoughtful mandatory vaccine policies in healthcare settings that account for ethical, legal, and more importantly, equity challenges and involve participatory processes with various stakeholders are justifiable. And healthcare system decision makers that have made the bold call to mandate new policies pending full approval, I think so now have the legal backing from at least one court ruling in Texas, as well as if you've seen more than 50 medical societies. And finally, I think the decisions and conversations will become much easier if we start thinking from 2 points. One, asking ourselves the question, would I support an immunization requirement if I could now know whether I would end up as a vulnerable ill patient, as a parent, or even as a child, or as a healthcare worker? And secondly, when I'm looking from where I'm looking, prioritizing my fiduciary duty as well as the reason of why health system exists, that is serving the best interest of our patients. So thank you so much for the attention, and I look forward to your feedback.
Thanks so much, Dr. Nasir. We'll move to Professor Thomas now. And I want to remind our participants to please put your questions for the panelists into the chat box. And after all of the panelists have spoken, we will move to the question and answer. Dr. Thomas.
Hi there. Hi, everyone. Thanks for having me today. And that was a fantastic presentation. So I'm coming to you from Canada. I'm in Toronto, though I work for the University of Ottawa. And we're having the same debates here in Canada. And we actually have no, it's actually quite rare here in Canada that healthcare providers, the hospitals are mandating vaccines for their workers. And it's no provincial government here has embraced the idea either. And I think it's for some of the same reasons that the previous presenter mentioned, right? It's primarily this concern about that this is a violation of patient autonomy, right? If we require healthcare workers to be vaccinated, then they've at the expense of losing their jobs or losing work shifts or being placed in a different setting within the workplace, that this is effectively going to coerce the healthcare worker into taking a medical treatment that they otherwise wouldn't opt for. And so with my colleagues Colleen Flood and Kuman and Wilson, we just recently put out a paper with the C.D. Howe Institute here in Canada, where we sort of looked at this argument from a more legal perspective and looked at some of the laws surrounding patient autonomy and so on in the jurisprudence. And this entire argument really does not wash, really. Insofar as the Canadian law protects patient autonomy, the protection is not, it would bar, for example, holding someone down and forcing them to receive an immunization, but it does not protect you against all of the incidental commercial or economic costs that might flow from not being vaccinated, right? So this really is just a non-starter of an argument, and I hope it gets before the courts sometime soon, because I think we're just paying a big price in Canada in terms of delaying moving forward with mandatory vaccine. And you may be aware that Canada's long-term care sector was really badly hit by COVID, and in part because we have itinerant workers moving from one long-term care center to another. So this is just a problem that could be readily solved through mandatory vaccination. And we were seeing a little bit of that in mandatory vaccination for long-term care workers, but we have a long way to go here in Canada. But I think a broader issue for me is that this argument, these sort of overblown arguments about patient autonomy, are also getting in the way of other public policy options we have. For example, the use of vaccine passports. Much the same arguments are being made. That if I don't have the freedom to enter a restaurant or a gymnasium unless I'm vaccinated, that somehow is an infringement of my patient autonomy. Again, an utterly spurious argument, but one that has just had the effect of kind of slowing down the embrace of vaccine passports in Canada. For now a year, we've got people making these arguments, and governments are just paralyzed in the face of these kind of false impression of a human rights violation. I should say, in the Canadian context, we see some other arguments coming up about this. It's not strictly an argument. It's not strictly the concern about patient autonomy. We also see people expressing concern that vaccine mandates infringe the right to health information privacy, right? So if you have to be vaccinated, then you have to provide proof of that. So you have to disclose information about your medical history to your employer or to with vaccine passports to wherever it is you're trying to enter. We've seen a lot of sort of prevalent discussion of equity issues. So this concern that marginalized populations, certain racial groups, for example, may be overrepresented among the vaccine hesitant, and that vaccine mandates will kind of disproportionately affect them. So they'll be the ones to lose their jobs or to lose work shifts and so on. So that's a second category of concern. And then a third category of concern is this worry about religious freedom and freedom of conscience, right? That we have to have some accommodations for people. And I think all of these concerns are answerable, but at least in the Canadian context, we've just seen governments kind of fold in the face of these fairly spurious arguments. My colleagues and I are all deeply concerned that we're going to go into a fourth wave of COVID without a kind of adequate toolbox to deal with this. It should, I mean, the mandating vaccination for healthcare workers should have been the low-hanging fruit on this, but we're not even there yet. So this is why we're so concerned. This is why I'm glad to be part of this discussion today. Thanks.
Thanks very much, Professor Thomas. And now let's move to Dr. John.
Thank you. I hope you can see my screen. Can you tell me if you can?
Yes. Okay,
great. Thank you for those excellent presentations, and thank you for the organizers of this Bioethics Interest Group. I will focus on the ethical aspects of COVID-19 vaccine mandates, and I've put together a few slides that focus on just the ethical issues, and I hope you find them useful. The root of the ethical dilemma behind the vaccine mandate is the conflict, as Dr. Nasir mentioned, between public health ethics and the right to individual liberty and autonomy. So a conflict between autonomy versus justice, individual versus public health ethics. He talked about the 4 principles within the biomedical ethical framework. Beneficence is self-explanatory. With non-maleficence, or the do no harm principle, some argue that a mandate removes the right to informed consent and therefore has the potential to cause harm to individuals, causing anxiety, low morale, etc. And others say that unvaccinated persons harm the community by refusing to get the vaccine. With regard to autonomy, a mandate with no exemptions at all removes the right to exercise autonomy. The right to consent to an invasive medical intervention, such as a vaccine, remains the protected right of the individual healthcare worker. Under an EUA, vaccine recipients must be informed of the option to accept or refuse. Many people use this as an argument. And an opt-out system should be considered because it gives the healthcare workers a right to express autonomy. Dr. Nasir had mentioned religious exemptions and medical exemptions. Vaccination benefits public health and promotes justice. It enhances community protection, that's herd immunity, and reduced transmission protects health system capacity, reduces healthcare worker shortages, and enhanced distributive justice enables healthcare organizations to fulfill their obligations to the sick and vulnerable, which is really at the root of the justification for vaccine mandates. Utilitarianism is a consequentialist ethical theory that determines right from wrong by focusing on outcomes. So proponents of this theory would say that coercive vaccination affords community protection and therefore is justified. So more coercion with higher immunity rates results in greater amount of good than less coercion with lower immunity rates. Now, there are objections to this theory, and they say that value monism is the idea that only utility is being stressed here and individual liberty is not given equal importance. There are critics of the biomedical ethical principles who say that it oversimplifies ethical decision-making. Ethical dilemmas are complex, as you heard, and cannot just simply be split into these 4 principles. Biomedical ethical frameworks are not always appropriate for defining and guiding public health programs, such as mandatory vaccinations. There are ethical decision-making tools. There are matrices, decision-making models, and checklists to identify and analyze ethical problems. And these are just 2 examples of ethical decision-making tools that are used for public health purposes. I won't go into them in detail. One of them was proposed by Nancy Cass, a 6-step ethics framework that asks all these questions. Is implementation fair? Can burdens be minimized? Because people are concerned about the side effects of the vaccine. We know that the side effects are very, very rare, but the risks do exist. The other bioethical decision model is by Thompson and Thompson. The least restrictive alternative principle is something that we should know about. It provides special protection for autonomy, and it proposes choosing a policy option that least restricts autonomy. So if there's more than one intervention, for example, people say that physical barriers are effective as well in preventing COVID-19, and that's less restrictive. It's not an invasive procedure like an internal barrier that the vaccines are. The intervention ladder has been described in this article that I've referenced here, and I've kind of modified the intervention ladder, which is applied to a vaccine mandate, to stress the differences between inducement and coercion. So it's important to know that there are alternatives. You may argue that they are not as effective as a mandate, but it's important to consider all these, try them first, and look at their effectiveness before implementing a mandate. Inducement is when you offer something that entices people to otherwise make choices that they would not make. It can be in the form of nudges or monetary incentives, and some have even proposed offering financial support for medical complications that may be related to a vaccine. Coercion is when there is an intentional threat. So you can have coercion with professional consequences as listed here, including termination of employment, and coercion with penalties that could be used as threats. Other issues to consider: dynamic justification. This has played a big role in all the medical organizations coming forward because you have the Delta variant. Epidemiologic conditions have changed over the course of this year, and the relative weightiness of reasons for a mandate varies under different circumstances, different countries. For example, you're not going to see mandates in New Zealand, where they've essentially eliminated hospitalizations. So in conclusion, ethical justification for a public health intervention like a vaccine mandate should be determined by applying ethical decision-making models that go beyond simple biomedical, clinical, ethical frameworks. It's important to lay the ethical groundwork in a transparent manner and involve a multidisciplinary team when making these decisions. And that's the end of my presentation. Thank you.
Thanks so much to Dr. John and to all of you for giving us an idea of how complex the questions that we're facing are: ethical, legal, policy, employment law, constitutional law, everything that is involved in these questions of mandating vaccines, even for, if we're only focusing on the population of healthcare workers. When we get into the ideas of vaccinating other groups of people, for instance, then how we classify groups of people, what the interests of the various parties are, become even more, which all of you have touched upon. It's what about the healthcare workers' right to choose? This would be focused on the autonomy principles Nasir was talking about. But I'd like for the three of you to speak about the right to choose. What are the elements, that sort of thing.
Can I comment on that?
Sure.
think, yeah, so definitely this is a complex issue. The possible objections of healthcare workers on judgment, I would say moral integrity, personal freedom, definitely needs to be prioritized. For example, they may be skeptic about the evidence of safety, effectiveness, or prefer or to delay or defer vaccinations, some may be just opposed on religious grounds, and libertarians may argue that individuals have the right to refuse acts that contravene their beliefs. Now, at the same time, I think so this is complicated by also by the fiduciary responsibility in the clinical relationship takes on a special significance when one individual is healthy healthcare workers and the other is a medically fragile patient. And if you look at more of the readings from Mel, and there is an acknowledgement that we do not live on an autonomous islands. Rather, individuals may be rightfully compelled to bear their fair share in the common defense, as we do, or in any other joint work necessary to the interest of the society, which they enjoy the protection. So I think so it becomes a little more complex, and especially in the healthcare environment where the fiduciary duty truly supersedes this issue of autonomy. And I think there is no complete lack of autonomy where people still have the right to choose not to work and seek other opportunities. And I may argue starting a 7 a.m. Rounding may be also a piece of coercion, and that doesn't go well with my beliefs. I have a right to choose not to work. So that's kind of where I've been thinking about this complex issue over the last few months.
Thank you. And I'd like to add to what Dr. Nasir had mentioned, the right to choose between your location of employment may be differentially applied to those who are not well off and who may not have choices. And so that should be regarded, sure, I agree that that should be taken into account, but people may not always have other options, and they may not have the ability to stop working for a few months if they are not financially well off. And I do want to mention that in public health, there's this thing called the precautionary principle, where in conditions of uncertainty, we have the power, or the government or authorities have the power to prioritize public health over individual rights, just because of the unpredictability. And there they say that inaction has to be justified more than a mandate. So that's the precautionary principle that's also being described in the ethical literature.
Thank you, Dr. John. Mr. Thomas.
Yeah, I guess one way of looking at this is to try to sort of define the core of what we're trying to protect when we say that we're concerned about autonomy, right? And it can't be that we're trying to protect every interest that anyone has, right? I mean, there's a Supreme Court of Canada ruling where the claimants were giving these kind of autonomy arguments for wanting to access recreational marijuana, and the court says, you know, one person wants the freedom to eat fatty foods, another person wants the freedom to golf, another person wants the freedom to smoke marijuana. A society that tried to protect all of these, treated these all as serious liberty interests, would be just ungovernable, right? So we need to kind of get at the core of what we mean by what aspects of life we're trying to protect by this. And so, and part of that question is, you know, are we trying to protect economic interests? Are we trying to say that someone shouldn't bear that, when there's a massive public health pandemic, and that people shouldn't be made to bear economic costs, which is what we're talking about here effectively. And just I think as a general principle, we don't want to go down that route. We don't want our law to be protecting people's economic interests against these priorities in public health. I just think that's a dangerous kind of inflation of the right to autonomy, I would argue. And I think the U.S. constitutional history has evidence of the problems you've had with this idea of sort of reifying economic rights to the point where, you know, the courts in the 1930s were overturning workplace safety rules under the theory that people had an economic right to contract freely and so on. So this is kind of, I mean, it's a bit of an abstract point, but it's just to make the point that talking about that, having these expansionist ideas of personal autonomy are just kind of dangerous, and they themselves are a dangerous precedent, I think.
Thank you, Mr. Thomas. We do have a question in the chat trying to tease out the idea of how the responsibilities of healthcare workers might be understood as perhaps different in kind, perhaps different in degree compared to vaccinations that are required to go to school or to participate in sports. We could even look at the Olympic athletes right now. We could look at the different universities that have required vaccinations, but not just universities. We could look at schools in general requiring vaccinations that are not COVID vaccinations or are COVID vaccinations. How do you all analyze from your perspectives the different interests of the people?
So from my perspective, I'm more focused from the healthcare workers' perspective, where I truly see our own community being at a significantly high risk, unprecedented that happened over the last year. So have a legal, from a healthcare system, legal responsibilities on improving the life of our own employees and making sure that they are at no risk. Then again, as I said, the first and foremost, our fiduciary duty and the reason why I exist for our patients, and any action or inaction that puts them at risk, we have to mitigate. It's kind of the same example. Yes, masking, social distancing is, you can equate that to having seat belts, but wouldn't you really want, when you're vulnerable, also had the protection of an airbag? I think so. That's really where from I'm seeing, and I think as a society, all of each organizations will have to look from two stakeholders, their own employees and the ones they are serving, be it sports, be it the airline industry, be it the universities. I think so those are going to be the key principle. And the autonomy of few individuals to object, unless and until it's not truly on a medical reason, I do not feel will supersede the safety and the benefits of the society at the whole, as an overall.
Thank you, and thank you for highlighting the idea of risk. What are the different risks? Dr. John or Mr. Thomas, I'm not sure.
Sure. Healthcare organizations have a responsibility to maintain a safe environment for everyone within the organization. Healthcare workers, patients, visitors who come in. And we have made a decision to work in organizations that serve vulnerable populations with medical conditions. And so that kind of justifies mandating this for healthcare workers in this environment, because we're not dealing with the general population. We're dealing with people who are vulnerable to diseases, and that's a key difference, as has been stated. So I think healthcare organizations are even more justified than other organizations to mandate the vaccine.
Yeah, I would agree with that.
Mr. Thomas?
I agree with that. I think as I said, I think that mandatory vaccination of healthcare workers is really the low-hanging fruit of all the discussions around requiring vaccination, so vaccine passports and so on. I mean, there are sort of perversities in opposition to vaccine passports that kind of complicate this. So I mean, it may well be the case that unless we have vaccine passports, everybody will have to be on lockdown again under the fourth wave of COVID, right? And so people who are opposing mandates in school settings and so on are just setting themselves up for a situation where we may be, just imposing, it's a kind of leveling down form of equality, right? We're making everybody worse off so that we can we're making everybody endure a net loss of autonomy so that we can avoid imposing a small cost on the autonomy of some individuals, right? We're going into general lockdown because we don't want to have vaccine passports, or we don't have vaccine mandates in places where the disease is spreading. So that's a special kind of perversity that I think that makes the sort of some of the opposition to vaccine passports even more absurd than the opposition to mandates in hospitals.
Thank you. I'm going to go now to Patricia Park's question in the chat. What are some of the most implementing mandatory vaccinations? Other ways to induce vaccination. I know that in the general public, there have been lotteries, there have been financial incentives, there have been other ways to, the first financial incentives were announced right after I had been vaccinated, right? Different states are doing different things. What do you think? Are there ways to encourage vaccination among the healthcare worker population without mandating? So without the mandatory, say voluntary, but with incentives.
I definitely think there is going to be room for that, more educational campaigns, bringing them on board. I think having discussions with hesitant workers, and most of that have really relieved either around not truly sure about the safety, religious beliefs, political beliefs are becoming a very common scenario these days. And and we've seen this before, influenza vaccination, without the mandate, the rates were hovering around 45, 50%, getting it up to 90 plus. We needed the mandates apart from the religious / medical condition exemptions. I feel, and I would hope that nudges and incentive would get us close to that 100% mark. Unfortunately, learning from lessons from history, I am very doubtful that that will happen. I think so mandate plus ensuring accessibility, ensuring that they are free, ensuring that the rationale of these mandates are transmitted as much as possible. And as you know, looking at Houston Methodist, we had almost close to 150 or less than 200 individuals out of 26,000 workers that refused vaccination. So that margin is going to be very low. And I think so once you have gotten to that threshold, additional inputs would have to be significant to achieve any minor benefits.
Yeah, I work within the VA healthcare system, the VA Maryland healthcare system, and there are specific incentives that have been attempted. For example, paid leave. Anyone who gets the vaccine gets 4 hours of paid leave automatically. But there's a limit. I think the people who do not want the vaccine for their own conscientious objection reasons or religious reasons are not likely to be swayed by the incentives. And so a mandate, I agree, will increase the number of people, and a mandate with exemptions allowed and with transparency will be kind of more justified than mandates with no exemptions and with just putting the policy out there. I think discussion is important, and incentives can help to a certain extent, but won't be as effective as a mandate. I agree with that.
Thank you both. Mr. Thomas, ideas for something less than a mandate?
Yeah, I agree with what the other things that have been said, giving people sick leave if they experience side effects, giving them paid time to go and get vaccinated. But I'm not optimistic that we're going to get where we need to be with that alone. So, and I don't have any other new ideas on incentives.
Thank you. So we have quickly time, let's say, for one more question, which essentially is the idea of fleshing out this idea of religious objections a little bit more, because, religious objections that we faced in the past, according to the question in the chat, products that contain bovine or porcine products or fetal cells used to grow cell lines. Like, what have you seen in terms of the religious objections? So medical exemptions seem to be more understandable if there are people who are immunocompromised or have other medical issues that would keep them from being vaccinated. But the religious objections are not necessarily clear to everyone. Like, why would somebody why would a person object religious based on religion?
I couldn't agree more. I'm lost at my end too on the religious objections. And so far, I don't think we have seen many. I don't know what everyone else's experience has been. Medical exemptions make more sense here, but there are no viable, as far as I know, to the best of my knowledge, any significant or prime religious objections that can be applied to this situation.
I think I read about the archdiocese, the Catholic archdiocese in New Orleans that raised objections based on the cell lines being obtained by previous abortions, but then the Catholic Church in Italy, justified the vaccine, saying that this should not be a cause for hesitancy. So even within religions, there is debate. So you're always going to have people raising objections. And it's going to be challenging for organizations to say, well, your religious objection is valid. You don't need to get the vaccine. I personally know a chaplain here who does not want the vaccine for that reason. So it does exist, and it is going to come up.
Yeah, I mean, specific faiths, I mean, the Christian Science faith, for example, believes in the use of prayer rather than science or medicine to overcome disease. Here in the Canadian context, we have a very generous reading of religious freedom where basically any conviction you have that has any connection whatsoever to your belief in God is protected. And then from there, we try to provide accommodations. So I assume that's how things would go here in Canada. I suspect that might be how things go in the US as well, that the assumption being that you have few enough people claiming religious exemptions that it's manageable from the standpoint of protecting patients. But and then, of course, there's also the category of conscientious objections. And in the paper that we just published, we have a section where we try to explain why conscientious objections, so sort of secular objection to vaccines or vaccine hesitancy, why that really would not be protected under constitutional protections of freedom of conscience, because for a variety of reasons. But, or partly because we can't have a society that just exempts people who have differences of opinion about science and so on. The state just needs to take a stance on these things, or else, it goes back to my previous point, that a society would be ungovernable if it tried to accommodate everybody who had idiosyncratic beliefs about basic questions of public health and science.
Thank you so much. We have, of course, used up our time because the panelists' presentations were fabulous, and frankly, the questions were fabulous. And thank you to you all for joining us today at the end of July. A special thank you to each of our panelists. It's been wonderful to get to know you for 58 minutes, and I look forward to speaking with you all again. For all of you, please pay attention to our next announcements about the next ethics webinar based on COVID-19, and we hope to see you again soon. Thanks so much.
Thank you.